The multifaceted challenges of determining gestational age and conception, date in human pregnancy, methods, discrepancies, historical context, and clinical implications. Introduction. Estimating gestational age and determining the precise date of conception are pivotal aspects of prenatal care with far-reaching implications for maternal and fetal health, clinical decision-making, and public health policy. The methodologies employed, ranging from traditional date recall to advanced ultrasound imaging and hormonal biomarkers, fundamentally shape how pregnancy is understood, monitored, and managed. Yet, each method comes with its strengths, limitations, and associated uncertainties, resulting in potential discrepancies that can significantly affect the trajectory of prenatal care. These dating variances are not merely technicalities. They influence benchmarks for fetal viability, the timing of medical interventions, and even legal definitions that underpin abortion policy and resource allocation. The complexities are further highlighted by historical anomalies and the evolution of dating standards, shifting the clinical landscape from reliance on patient memory to the precision of modern technology. This report offers an in-depth analysis of the multifaceted challenges and evolving landscape of gestational age estimation, integrating clinical, historical, ethical, and policy dimensions. 1. Primary methods of gestational dating. Comparative analysis. 1.1 Overview of dating methods. The determination of gestational age rests primarily on three methodologic pillars: last menstrual period, first trimester ultrasound biometry, notably crown rump length measurement, and ovulation conception tracking via hormonal or physiological markers. These approaches, often used in tandem, provide triangulated estimates of the gestational timeline, but exhibit varying accuracy, accessibility, and clinical consequences. Table 1. Comparative strengths and limitations of gestational dating methods. Last menstrual period, LMP, non-invasive and universally accessible. Immediate utilization at first consultation. Aligns with traditional standardized dating conventions, relies on accurate recall, assumes regular cycles and typical ovulation timing, prone to errors with irregular menses, recent contraception or postpartum cycles, can misdate pregnancies resulting in misclassification of preterm or postterm gestation. First trimester ultrasound, CRL, objective, quantifiable, most accurate in first trimester, reduces dating error, especially in uncertain LMP, requires access to imaging. Operator dependent. Accuracy declines after first trimester, gold standard for revising dating if LMP and ultrasound differ significantly. Ovulation conception tracking, potentially exact identification of fertilization, valuable for women using ART or fertility tracking tools. Hormonal confirmation, limited population availability, not universally practiced. Ovulation detection can be imprecise due to variable hormone surges. Useful in select populations, less commonly forms primary clinical basis. In clinical contexts where pregnancy is suboptimally dated, that is, lacking early reliable last menstrual period or timely ultrasound, a combination of methods or post-hoc estimations is used, further emphasizing the complexity and necessity of nuanced clinical judgment. 1.2 Last menstrual period LMP dating. The LMP-based method remains a mainstay due to its simplicity and immediate availability at the first prenatal visit. Patients typically recall the first day of their last menstrual period, from which gestational age is counted, assuming a regular 28-day cycle and ovulation on day 14. Importantly, this model presumes accurate memory and typical physiology, which is often not the case. Menstrual cycles exhibit inter- and intra-individual variability, influenced by stress, weight changes, illness, and contraceptive use. Notably, studies report that up to 50% of women may have inaccurate recall or irregular cycles, resulting in potentially significant errors, sometimes exceeding a week or more, in gestational estimation and consequently in determining due dates. Such errors bear substantive clinical repercussions. In the context of scheduled elective deliveries, a misdated pregnancy may precipitate iatrogenic preterm birth with attendant morbidity and cost. Conversely, failure to recognize true post-term pregnancies can delay necessary intervention, raising risks for stillbirth or maternal complications. 1.3 First trimester ultrasound biometry. First trimester ultrasound specifically, the measurement of the crown rump length between 7 and 13 weeks gestation has emerged as the most reliable method of dating, particularly when LMP is uncertain or discordant with observed fetal growth. The American College of Obstetricians and Gynecologists, ACOG, and the Society for Maternal Fetal Medicine recommend the use of ultrasound dating when the discrepancy between CRL estimation and LMP-based calculations exceeds certain thresholds, typically more than 5 to 7 days in the first trimester. Ultrasound dating is lauded for its objectivity, reproducibility, and correlation with established fetal biometry charts, with error margins of a few days during optimal time windows. Accuracy diminishes progressively in the second and third trimesters. Yet its accuracy is contingent on operator skill, equipment quality, and fetal position. In regions with limited access to imaging, the benefits are not universally realized, a challenge now being addressed by emerging AI-powered portable ultrasound tools with real-time gestational age estimation algorithms. 1.4 Ovulation and conception tracking. A more precise, biologically grounded approach is available for select populations using ovulation prediction kits detecting urinary LH surges, serial hormonal assays progesterone or estradiol, or advanced fertility tracking devices. These methods can pinpoint the day of ovulation or even conception in vitro fertilization, representing the true biological start of gestation. While potentially offering the most accurate conception dating, these approaches are impractical for widespread use due to costs, required technical literacy, and the need for preconception tracking. In addition, ovulation itself can vary substantially, even among women with regular cycles, further complicating broad applicability. Conclusions from systematic reviews suggest that, outside of assisted reproductive technology (ART) populations, ovulation tracking remains adjunctive rather than primary for routine gestational dating. Nevertheless, it provides a valuable research and counseling tool in cases of known delayed ovulation or when natural conception timing is of specific interest. 2. Discrepancies between dating methods. Clinical impact analysis. 2.1 Nature and magnitude of discrepancies. Discrepancies between dating modalities are not uncommon, particularly when LMP and ultrasound-based estimates diverge. Such differences may arise from recall biases, irregular menstrual cycles, late ovulation, early embryonic arrest with delayed natural expulsion, missed miscarriage, or methodological errors in ultrasonographic measurement. Studies indicate that, depending on the population and clinical setting, up to 15 to 25% of pregnancies present with significant dating discordance, commonly necessitating protocol-driven reconciliation in favor of ultrasound-derived biometry. 2.2 Impact on fetal development timelines. The imprecise alignment of gestational age estimates can shift the perceived timeline of fetal development. For instance, a pregnancy dated by LMP but conceived after delayed ovulation might appear older than it truly is by as much as 1 to 2 weeks. This temporal displacement can lead to confusion in tracking fetal growth patterns, with potential misclassification of small for gestational age or growth-restricted fetuses if ultrasound findings do not match expected biometric norms. Conversely, an underestimated gestational age may mask fetal underdevelopment. 2.3 Shifting of prenatal care benchmarks. Benchmarking key prenatal interventions, such as first and second trimester screenings, fetal anomaly scans, diabetes screening, and timing of corticosteroid administration in threatened preterm labor, depends critically on accurate gestational dating. Inaccurate age estimation can lead to missed windows for effective intervention, or alternately unnecessary testing and resource utilization outside optimal periods. For example, the timing of anatomy scans, usually at 18 to 22 weeks, must be correctly anchored to fetal maturity. A misdated pregnancy could result in incomplete assessment of organogenesis or false positives for anomalies, driving up false reassurance or unnecessary anxiety and further interventions. 2.4 Influence on clinical decision-making. Dating discrepancies can profoundly shape major clinical decisions, particularly around the threshold of viability between 22 and 25 weeks, induction timing for post-term pregnancy, and interpretation of fetal growth disturbances. For viability assessments, a misclassified 23-week fetus might be inappropriately triaged, either subjected to intensive care interventions with low success probability, or, conversely, denied potentially life-saving support if believed to be pre-viable. In regard to induction or elective cesarean timing, errors in dating may prompt preterm delivery or missed interventions in the case of genuine postdates, the latter significantly increasing the risk of stillbirth, as observed in large cohort studies on late-term pregnancy morbidity. 2.5 Policy and legal implications, abortion thresholds. Gestational age estimation is increasingly salient in the policy and ethical arena, notably shaping abortion legislation, which in many jurisdictions is predicated on fixed gestational limits, for example 20, 22, 24 weeks. The method used to estimate gestational age can thus directly affect access. For instance, a woman with irregular menses who is erroneously dated as post-threshold by LMP may be legally denied abortion even though her actual conception date is later. These high-stakes discrepancies are a source of ongoing ethical debate, as no single method is infallible and discrepancies of over a week are medically plausible even in advanced clinical systems. 3. Growth trajectory variations, LMP versus crown rump length, CRL, and downstream implications. Here's the text to convert. 3.1 Illustrative example, LMP versus CRL dating. Consider a scenario in which a woman with irregular cycles recalls her last menstrual period as 6 weeks earlier, but ovulated on day 28, 2 weeks later than standard. If gestational age is calculated by LMP, her pregnancy is already 6 weeks at the time of her first consultation. However, if a first trimester ultrasound reveals a CRL corresponding to only 4 weeks, a significant discordance emerges. The ACOG and international protocols instruct that in cases where ultrasound dating in the first trimester differs from LMP by more than defined thresholds, typically greater than 5 to 7 days, clinicians should revise the estimated due date, EDD, to the ultrasound date to minimize risks of mismanagement. This underscores the clinical point that CRL-derived dating supersedes uncertain LMP-based estimates in determining true fetal age, thereby refining the precision of the entire prenatal timeline. 3.2 Impact on fetal growth interpretation and interventions. Such a shift in gestational age estimation recalibrates all subsequent growth projections, biometric centiles, amniotic fluid assessment benchmarks, and Doppler studies are all indexed to revised gestational age estimates. This recalibration is critical in distinguishing normal growth patterns from pathological restriction or overgrowth, macrosomia. For instance, a fetus initially classified as below the 10th percentile for weight by LMP dating might actually be in the normal range when indexed to CRL-determined gestational age. Therefore, accurate dating averts unnecessary interventions, maternal anxiety, and costly monitoring. Conversely, persistent dating errors can misclassify at-risk pregnancies, undermining targeted surveillance and timely preterm interventions. 3.3 Downstream implications, resource allocation and interventions. The allocation of resources, such as specialized neonatal care at the border of viability, in utero transfer to advanced centers, or management of multiple gestations, depends on accurate gestational age assessment. For example, resource-intensive interventions like administration of antenatal corticosteroids for fetal lung maturity are effective only within certain gestational windows, typically 24 to 34 weeks. Earlier administration confers no benefit and unnecessary exposure, while later administration is futile. Similarly, induction protocols designed to limit adverse outcomes in prolonged pregnancies require confidence that the fetus is truly post-term, greater than 41 weeks, Misestimating gestational age may inadvertently result in excessive late preterm or early term births, with long-term consequences for neonatal morbidity and health system burdens. 3.4 Ethical considerations. The persistent potential for inaccuracy in dating raises ethical questions about the fairness and appropriateness of both clinical and policy decisions, particularly when life-altering interventions up to and including abortion or neonatal intensive support at viability hinge on precise gestational milestones. This is compounded in resource-limited settings, where access to high-quality ultrasound or hormonal assays is inconsistent, increasing the risk for inequity in care and adverse outcomes. Standardized communication of dating uncertainty, transparent counseling regarding margin of error, and flexible protocol adaptation are critical for maintaining ethical integrity and patient-centered care within the inherent ambiguities of gestational age estimation. 4. Historical perspective, the enigma of extended pregnancies. 4.1 Beulah Hunter's 375-day pregnancy, 1945. Perhaps the most sensational account in the annals of pregnancy duration is Beulah Hunter's 375-day gestation, reported in Los Angeles in 1945. The case, widely publicized and medically documented at the time, chronicled a woman giving birth after what was reported to be a 53-week pregnancy. Hunter's case has since fueled debate for decades regarding the natural limits of human gestation and the reliability of pregnancy dating in the pre-ultrasound era. Contemporary retrospectives, however, point to significant uncertainties and potential flaws in the data. The primary details relied heavily on patient memory for LMP, with absence of early pregnancy tests, hormonal assays, or serial ultrasonography. Some hypotheses suggest that Hunter may have experienced an early missed miscarriage, with subsequent conception in an immediate cycle that went unrecognized, thereby inflating the presumed pregnancy length. Nevertheless, the case remains a striking illustration of the limitations inherent in LMP-based models, highlighting both human fallibility and the absence of objective biological cross-checks in mid-20th century obstetrics. The prodigious pregnancy came at a time when medical observers could do little more than estimate fetal age post hoc based on birth weight, clinical examination, and maternal recall, a practice susceptible to errors measured in weeks, if not months. 4.2. The second longest verified gestation, 317 days. A more clinically credible account exists for a pregnancy lasting 317 days, approximately 45.3 weeks, attributed to documented delayed ovulation and implantation, closely monitored with available hormonal assays and careful clinical follow-up. In this case, the delayed conception was substantiated with contemporary fertility tracking, resulting in a healthy birth, a rare but biologically plausible occurrence. Such exceptions, though rare, highlight the inherent natural variability in menstrual cycles, ovulation, and the multiphasic nature of reproductive endocrinology. They also reinforce the potential for outlier gestations that, while within the statistical fringe, shape the boundaries of normalcy and clinical vigilance. 4.3 Modern gestational norms versus historical outliers. The contrast between these historical cases and the contemporary norm, where pregnancies delivered beyond 42 weeks are considered post-term and subjected to escalated monitoring and intervention, demonstrates a seismic shift in both expectations and practice. Today, the overwhelming majority of pregnancies are delivered between 37 and 41 weeks, with less than 5% extending beyond 42 weeks in jurisdictions with robust prenatal systems. Advanced dating tools and tightly defined clinical protocols render extended gestations exceedingly rare, and if verified, typically prompt aggressive intervention rather than passive observation. 5. Advances in gestational age precision, imaging, hormonal tracking, protocols, and the contemporary landscape. 5.1 Imaging revolution, from palpation to real-time ultrasonography. The advent and widespread adoption of ultrasonography have represented a paradigm shift in obstetric care. Early pregnancy real-time imaging allows for direct visualization and precise measurement of embryonic and fetal structures, superseding subjective estimates based on fundal height and maternal milestones. The accuracy of CRL measurement in the first trimester with dating errors, typically less than 5 days, underpins virtually all major clinical protocols for pregnancy management, facilitating timely and tailored prenatal care. Recent innovations have further expanded access and accuracy. The miniaturization of imaging devices, the application of artificial intelligence-driven image interpretation, and automated gestational calculators now allow for cost-effective, operator-independent dating even in low-resource or remote settings. For example, portable ultrasound devices paired with machine learning have begun to close the accuracy gap in areas lacking traditional radiology services. 5.2 Hormonal tracking serum and urine assays. Alongside imaging, advances in hormonal assays, including the quantification of human chorionic gonadotropin, luteinizing hormone progesterone, and estradiol, enable more biologically precise mapping of conception, ovulation, and implantation events. Particularly in RT contexts, the use of serum markers allows for near-exact pinpointing of gestational initiation. In natural conceptions, commercial ovulation prediction kits, urinary LH surge detectors, and fertility apps employing physiological metrics, such as basal body temperature and cervical mucus monitoring, provide a more individualized dating map, though with varying sensitivity and specificity. These tools are increasingly integrated into preconception and early pregnancy counseling, empowering women with data while supporting clinicians in managing cycle irregularities or subfertility. 5.3 Standardized protocols and guidelines. Clinical societies including ACOG, RCOG, and WHO now provide rigorous, evidence-based guidelines to harmonize gestational age estimation practices globally. These protocols instruct clinicians to default to ultrasound-based dating in the event of significant LMP discordance, to clearly document the method and basis of dating in the clinical record, and to communicate the margin of error to both patients and multidisciplinary teams. Multidisciplinary consensus obstetricians, sonographers, reproductive endocrinologists is emphasized in complex or ambiguous cases. In addition, the increasing use of electronic medical records and gestational age calculators, often automatically integrating LMP ultrasound, and, when available, ovulation conception data, facilitates both documentation and protocol adherence. 5.4 Artificial intelligence and machine learning. One frontier area involves the application of artificial intelligence and machine learning to both imaging and data integration. AI-assisted ultrasound interpretation can now automatically measure CRL, detect anomalies, and reconcile discrepancies with LMP or prior scans, reducing the skill gap barrier in low-resource contexts. Early data indicate that AI-powered dating can match or exceed expert consensus accuracy, particularly when integrated with longitudinal data points, for example, serial scans, hormonal profiles. Moreover, emerging platforms leveraging large-scale patient data can identify atypical gestational trajectories, including rare delayed ovulation implantation or growth disturbances, providing real-time alerts to clinicians and personalized risk stratification for both early and late interventions. 5.5 Continuous recalibration of clinical thresholds. With enhanced precision has come a tightening of clinical thresholds and more proactive management. The margin for error in defining the lower limit of viability, currently 22 to 23 weeks in advanced centers or post-term status, greater than or equal to 42 weeks, is continually decreasing, providing the opportunity to maximize outcomes while minimizing unnecessary interventions. At the same time, the clinical community remains vigilant for rare but plausible outliers, grounded in the lessons of historical anomalies and the vagaries of human biology. This continuous recalibration is echoed in policy settings, where clarity of dating method, clear communication of uncertainty, and interdisciplinary review are becoming standard practices, particularly for contentious or irreversible decisions, that is, abortion provision, neonatal resuscitation at viability, fetal surgery eligibility. Conclusion. The determination of gestational age and conception date in human pregnancy, while on the surface a technical exercise, proves to be a deeply multifaceted challenge at the crossroad of biology, technology, human error, and clinical policy. LMP-based dating, though accessible, is fraught with variability and memory-dependent inaccuracies. First trimester ultrasound provides objective and reproducible results, becoming the gold standard in the absence of precise ovulation tracking. The emergence of hormonal assays and fertility tracking further refines precision for select populations, but is not yet universally scalable. Discrepancies between dating methods remain highly clinically significant, with the power to alter fetal development timelines, trigger or defer critical interventions, shape the ethics and legality of abortion provision, and determine resource allocation for both mother and child. The evolution from historical outliers such as the contentious case of Beulah Hunter's year-long pregnancy and the more plausible 317-day gestation to contemporary precision underscores the advances achieved through imaging, biomarkers, and systems-driven protocols. Despite technological progress, the inherent biological variability and imperfect nature of all dating methods guarantee that a margin of error persists, a reality demanding humility, transparency, and patient-centered flexibility from all involved in obstetric care. As AI and systemic standardization further tighten gestational boundaries, the onus remains on clinicians and policymakers to balance data-driven certainty with ethical nuance and individualized care. In this ever-evolving intersection of science and policy, one constant remains. The stakes for women, children, and the broader health system demand that gestational age determination continues to advance in accuracy, equity, and ethical integrity.